Hi, I'm Robert Spencer from the Ann Arbor VA in the neuropsychology section. We're going to be talking today about psychometrics. I've titled this Psychometrics 101 because, as I think will become apparent by the end, psychometrics is a very broad topic, but I want to give you something that will be useful. And given that I am in the neuropsychology section, I am gearing this mainly towards people who are in neuropsychology, but I think that you'll find that it's also applicable to people in medicine more broadly. As far as conflicts of interest, I have nothing to disclose. This is mainly dealing with math and how do you sort of extract good information from papers, and so there are no conflicts to disclose. Key terms. Now, I will introduce these terms to you very briefly now. No need to know this right off the bat because we're going to have a lot of elaboration in subsequent slides. But there's reliability, and that's essentially, are you measuring something precisely? Validity, what is the significance of the scores that you obtain? Sensitivity and specificity, deal with how accurate your predictions are. Likelihood ratio is something that's very useful that you'll find that you can do if you know your sensitivity and specificity. You can do a little bit of mathematical trickery and get something that can be very useful in clinical work. And logistic regression. And I'm not going to speak broadly of logistic regression, but I'm going to target it more towards what you would be able to do in a prediction setting, such as neuropsychology. So the outline, very broadly, I'll discuss your learning objectives, and then very briefly I'll talk about descriptive psychometrics because I want to give relatively more weight to diagnostic psychometrics. And then I'll wrap it up very briefly. Learning objectives is that you are at least familiar with some basic psychometric terminology and that you're able to calculate likelihood ratios. There are several steps that I outlined in the subsequent slides that I think will make it as easy as 1, 2, 3, possibly 4 and 5. And then identify some limitations in most of the research that's published so that you don't carry yourself with too much confidence thinking that the numbers that you obtain are as precise as sometimes they appear to be. So why quantify? There are a lot of ways of gathering information from people. You have what your patients tell you or what your research subjects tell you. You have the reports from knowledgeable informants. You have observations that you yourself make. And it's important to remember that even experienced clinicians have limitations. And all of methods, including the psychometrics we'll talk about, have limitations that need to be acknowledged. It's a good start, and at least with neuropsychology, to start with standardized administration and testing, and then from there to quantify, but merely quantifying is not enough. It's quite often the case that, when you think about sports, for example, people are dazzled with numbers. Numbers, numbers, numbers. It's good to know what is the relevance of those numbers. And so researchers, it's on you. You have to demonstrate what is it that is meaningful from these numbers. Now, very broadly, almost to the point of being inaccurate, there are two main spheres of psychometrics. And they're not exclusive, but usually if you read about it in a textbook chapter, they're discussed in separate chapters. And each deal with how you interpret scores and how you relate those scores to various reference groups, whether they be healthy people or not. Number one, you compare your groups with healthy individuals matched on relevant demographic variables, and you get scores, usually expressed on how well or how far people deviate from the mean of the obtained scores in the reference group. So am I below average? Am I above average? Those kinds of things are captured in the first group of psychometrics. And the second is diagnostic. So I determine here caseness. Is it a case or is it not a case? So does someone have a diagnosis of Alzheimer's disease or do they not? Is a person likely to be able to return to work within 6 months or are they not? Approach one. And this is very brief. Approach one is quantifying performances according to the normative expectations. Neuropsychology does this quite a bit. So you'll see scores expressed in terms of standard scores or T-scores or Z-scores. It's all really the same thing. just how far do people deviate from the norm. Your reliability for those things can be measured in a lot of ways, and I highlight some things here. So inter-rater reliability. Do two people who are looking at the same behaviors or same general set of behaviors see things in the same way? That's inter-rater reliability. Internal consistency. Over the course of a sample of behavior, are you finding something that is relatively consistent? Does it cohere? So your score on the first half of an IQ test, does it correlate with your score on the second half of the IQ test? And you would expect that it would. Alternate form reliability. Sometimes people get tested on the same thing again and again. They get used to the specifics. It's good to have another form of the test. You would expect that those two tests would correlate pretty highly. There's also retest reliability. And this area of psychometrics deals with the area of practice effects. As the saying goes, you can never throw a rock into the same river twice, and the idea between that or behind that is the fact that the river always changes. Once you give somebody a test, they are forever changed. They've seen that test and it's no longer novel. So it's good to know how much practice effects are expected. And there are reliability coefficients, and practice effects will help you to get how much change would be expected over time. If someone scores a 52 on a test and then they score a 54, the question is, could that be due to practice effects or random chance? Or is that an actual change in scores? Well, those statistics will help you with figuring that out. And tests are validated with this approach to the degree that they correlate with similar measures. And it's even better if they don't correlate with what they shouldn't correlate with. So a test of memory should correlate with another test of memory, but probably shouldn't correlate with someone's shoe size or social security number, since those are supposed to be unrelated to memory. And then approach number 2, and this is what I'm going to spend the bulk of the time talking about. Keeping in mind that what I just mentioned in the previous 2 or 3 minutes is something that some people have spent careers researching. What I'm going to talk about here is something people have also spent a long time researching, but I'm going to try to give you something that's tangible out of this. And you'll see this in healthcare a lot. When people are in healthcare, they're often asked to make dichotomous decisions, yes or no, even acknowledging that the truth is probably somewhere between yes and no. So if someone were to ask, is it going to rain today? Well, you can provide a yes or no answer, but sometimes you have to decide at what point is rain so likely that you're going to need an umbrella. In clinical work, you have questions like, can this patient return to work? Will this patient require accommodations? Does the patient have a psychotic disorder as defined in the DSM? And are the data gathered from today's neuropsychological evaluation a valid representation of her true abilities? As you can see, that some of these things you might not be able to gauge with 100% accuracy, either in a yes or a no fashion, but you're often asked to give a yes or a no and sometimes express things in terms of probability. And I think the following slides will help you do that. I talk about some general research considerations here, and I'm going to highlight these as we go, especially at the end. Researchers tend to use cut scores. And this is the score that, through their statistical methods, have been found to best discriminate between people who are yes or no. Do they have the diagnosis or don't they have the diagnosis? And healthy individuals are often used as the comparison group. So compared to people with Alzheimer's, age-matched healthy people, how do they differ? That's the general thrust of the research in this area. Relevant constructs are usually treated as dichotomous variables. So if you think about that in terms of height, when does someone become tall? 6 foot? 6'8"? As a researcher, you'd have to decide. And a lot of times variables that are really represented on continua are dichotomized. And scores are selected from a long continuum of cut scores that you're going to use in your tests. I'll give you some examples. And it's often a trade-off. Are you going to pick a high cut score that's very strict or a low cut score that's very inclusive? And these are traditionally measured in terms of sensitivity and specificity, terms that you'll become pretty familiar with very soon. Sensitivity is defined as the proportion of cases accurately classified. So if you have a sample of people and you're studying, let's say, Alzheimer's, and you're trying to have a test that's very sensitive, it's sensitive to the degree that it captures as many cases as possible. Now its cousin is specificity, and that's the proportion of non-cases accurately classified. I could easily have a test with 100% sensitivity of Alzheimer's. I just diagnose everyone with Alzheimer's. It would be 100% sensitive and useless. Specificity is the necessary twin. And there's always a trade-off between sensitivity and specificity, and each researcher needs to decide what are they going to use as their cutoff. And I think this next example will give you a pretty good idea. This is the matrix. You're tapping into the matrix here. Look at the colors. You have green for accurate, you have red for inaccurate in this example here. At the top of the matrix, you see, are they in reality positive or negative? Positive means they have the characteristic, and negative means that they don't. Do you predict, as far as the rows here, do you predict positivity? Do you predict negativity? I predict the person has Alzheimer's. Based on my scores, I predict the person does not have Alzheimer's. And you can see with this matrix, you pretty much capture a 2-by-2 scenario pretty well. So in this case, I predicted they had it, and they had it. I predicted they had it, and they don't in reality. I predict they don't have it, but they actually do. And I predict they don't have it, and they actually don't. That's the matrix. And usually when you're reading a paper, even if the reporting is not that great in the results section, you can usually abstract enough information to create this matrix. If anybody debates whether a paper of mine is actually mine or if somebody else printed it off, usually I have a doodle in the corner of one of these matrices, and people will know that's actually my paper, meaning that I printed it out, not that I necessarily wrote it. Positive predictive power. Positive predictive power is a good concept for a clinician because it deals with, of the people who scored positive on your test, how many were actually positive. So what you do is you divide the number of people in this cell by this cell. Negative predictive power. Of the number of people that you predict to be negative, how many are negative versus positive? So as you see here, the correct one, you predict negative, it's actually negative. You predict negative is actually positive. The division would be this divided by this. Sounds simple, but I'll show you why that doesn't always play in a little bit, but let's play around for a little while. Right here, I look in the house and I'm looking for John. Pretend this is a house with a lot of rooms. I look in the house and I see John. The house is positive for Johnness. Well, as you can imagine, if I see John in the house, John's in the house. Positive predictive power in this case is going to be very high. But I look in the house and I don't see John. Well, that doesn't mean John's not in the house. He might be in the bathroom or he might be in the kitchen. So in this case, negative predictive power would not be all that helpful. And while we're doing examples, let's take it to the real world in law. We have a gentleman in this example. Will he reoffend? In reality, and this is made up data, so please don't go citing this anywhere. Let's say that 10% of people reoffend. So you have 100 yeses, 900 no's. But you were deciding whether to grant parole. Now there's a few approaches you can take. Just say yes, he'll reoffend. You're going to be right 100 times, you're going to be wrong 900 times, but you'll get 100% sensitivity. This divided by this, 100%. Problem is nobody gets parole and you're keeping 900 people that would not have reoffended locked up. Not good, not ideal. Or you could just say no. Well, you're going to be right most of the time. Your negative predictive power is going to be 90%. You say no, well, Yeah, okay, you're wrong 100 times, but you're right 900 times, so 10% of the time you're wrong, 90% negative predictive power. Problem is, you have 100 people out there reoffending. In real life, you have to pick something that's in the middle, and it really depends on comfort level. It depends on how serious the yeses versus the nos are, and that's something that in every setting you have to decide. Let's take something that's life and death. Ebola. Now, as of this recording, the Ebola epidemic, or the scare in the United States, is a few years old. But at the time in healthcare, it was very common to screen for Ebola. Ebola being contagious risks an epidemic if it gets out. In this case, you want 100% sensitivity. The safest way is just to say everyone is positive for Ebola in the screen and then do follow-up medical testing to see if they actually have Ebola. But as you probably could guess, that's just not going to work. It's just way too many people to screen. So what do? Well, what healthcare did is they asked some very broad questions that captured a lot of people, and you get something like this. What is the sensitivity of this test? I'll give you a hint. Actually, I'll give you the answer. It's this divided by this. It's 100%. And what they asked is if people had been to Africa or if they had exposure to people who had been. Well, that ended up, and this is fake data as well. Please note the fake data. But in this data, it's 100% sensitive. The positive predictive power, well, you predicted yes, you were right 5 times out of 1,000. It's 0.5%. The reason that it looks so good when you look at it through sensitivity and so bad when you look at it through positive predictive power is because it doesn't occur very often. Ebola was something that was very rare. Even in my fake data here, I think I might have inflated the incidence of Ebola. So this is a case where the medical community wanted 100% sensitivity, even if they were wrong a lot of times, because the follow-up medical interventions would have vindicated them. Schizophrenia. I have an example of a test. I'll give you some background. You don't want to miss a diagnosis of schizophrenia because you could miss out on getting somebody some necessary treatment if you miss the diagnosis, or you could end up giving somebody some medications with some heavy-duty side effects if you falsely diagnose yes. So you want to maximize accuracy as much as possible. Well, there's test X, and something I made up, but I think that the actual statistics will be pretty close to what I'm going to present here. Is it a good test? It has 80% sensitivity and 80% specificity. On the surface, looks like a real good test. And here's what it would look like in the matrix. Sensitivity, 80 divided by 100. Specificity, 80 divided by 100. Positive predictive power, 80 divided by 100. And you probably guessed it, 80 divided by 100 for negative predictive power. By these stats, it looks like a great test. Positive predictive power. Okay, we're cooking. But what if we reduce this to a 2% base rate? Aha! Look at this. Out of 200 people, 100 had schizophrenia, 100 did not. You'll see that in research studies a lot. Research studies will have sort of falsely an even base rate. And you want to make sure that you don't mislead people into thinking that 80% of people that score positive on test X have schizophrenia. By the way, test X is smoking. The question would be, have you smoked a cigarette in the past week? As I think is very apparent now, you would not want to use that as your sole diagnostic test. Otherwise, you would offend a lot of people outside as you walk by buildings. So as you see, schizophrenia, not schizophrenia, it's not the real world. Here's the real world. You have about a 2% base rate, and I'm being a little high. The base rates vary depending on what source you use, but 2% is on the higher end. In this case, you have 2% base rate. Of the times you say yes, you predict yes based on whether they've smoked, how often are you right? 80 out of 1,060 times. Not something to brag about at a dinner party. So, what's the percent chance you're right? It's 7.5%. Not too good. Now remember, prior, you just know a person exists. You got a 2% chance that the person has schizophrenia. If they say yes, 7.5%. If you say no, it's 0.5%. Of course, the odds are higher if the person smoked, and they're lower if they didn't. But the bottom line is that you would not want to use that as your sole diagnostic test. Likelihood ratios to the rescue. What are the increased chances of schizophrenia given a positive test result? Well, here's the formula you should use. Here's a formula not only should you use for referencing my slides that we have out here, you should commit this to memory because it will really help you. If the test is positive, your formula is sensitivity divided by 1 minus specificity. And if it's negative, formula is 1 minus sensitivity divided by specificity. Probably best to represent this in form of a decimal if you're doing the calculations. I'll give you an example. The smoking example. Yes, sensitivity was 0.8, specificity was 0.8, so you do 1 minus that, you get 4. On the other hand, if it's no, you end up with 0.25 because the calculations go 0.2 divided by 0.8. Your next question, and this is the crucial one, what is it more likely than? So you say that your odds of having schizophrenia are increased if you smoke. Well, increased from what? Well, here's how you do the calculations. You first have to start with what did you think the odds were in the first place? Now, I said 2%. And the reason I said 2% is because that's what it is based on the general population. Now, if you're in a community clinic, the odds are going to be different. It's probably going to be a bit higher, especially if it's a mental health clinic. So you start with that as your prior probability, and you convert your prior probability into odds. So let's say that the odds are 40%. So it's 0.4 divided by 1 minus 0.4. Your odds are 0.67, for example. You then multiply by the likelihood ratio that you got for your test, and you get the magical post-test probability. This is the thing that will tell you what is the percent chance the person has condition X. That's not often going to be apparent in the studies that you read, but you will be able to get this data, and if you know the prior probability from the base rates, you'll be able to get this beautiful, beautiful formula here. Odds equals odds divided by 1 plus odds. What does that look like? Literature says 2% odds, or 2% chance of having schizophrenia. You take that probability divided by 1 minus probability, you do the math, you get 0.0204. Multiply that by 4, which if you recall, was what you would get if you used the 80% sensitivity and 80% specificity. You get 0.8. 0.816 divided by 1.0 or 1 plus 0.0816 equals 7.5%, which should sound familiar because that's what we got when we looked at the matrix from before. Now let's say your clinic has a 25% base rate of schizophrenia. Well, that changes everything, except for the math. You're still going to follow the same steps, but you're going to use 25% as step 1. So if you use the numbers, probability of 25, you're going to calculate the odds. 0.25 divided by 1 minus 0.25 equals 0.333. Multiply that by 4, because that's what you got from your sensitivity and specificity numbers. Your new probability is 1.33333 plus, or divided by 1 plus 1.33333. And you get 57.4%. Now you start to see the beginning phases of a test that looked like it was pretty limited. Does a person smoke? And now you start to see that it really changes things. So you're going into your additional testing assessment for schizophrenia, and you're seeing that you have a 57% chance this person has a condition, That's something that's good to know from a clinician, when before you would have just been guessing, you would have said 25%. Sometimes people complain, rightly, that using cutoffs artificially constrains them because a person has to be positive or negative, and the predictor values are a lot of times exist on a continuum. So is a person obese? Well, let's say they have a BMI of 34 versus 35. Now let's say your cutoff is 35. You call the person obese for having a BMI of 35. Well, they just had a sandwich. If you had asked them before they had the sandwich, they would have been a 34, they would have been considered not obese. With logistic regression, you can use the variables to correlate with one another. They can be along a continuum, and you make sure that the variables are optimally weighted, because sometimes some variables that are predictive mixed in with other variables that are predictive will give you much different results in the end, because some are just more important than others. There's some great examples in the reference that I'm going to show you a bit later. There's also some great examples that you'll see in some of the work by Malcolm Gladwell for popular literature, and how some examples of prediction can go awry because people don't know how to weight things unless they have a good formula that helps them. Now, these are some research considerations as a consumer and as a producer of research. So cross-validation is essential. Once you get your cut scores, once you get your regression weights, and you can use regression to get predict probability, it's something that requires its own set of videos to do. But once you have your information on what the optimal weights are and what the best cut scores are, you have to grab another sample of people and see if it still holds up. The danger is always that the formula works in the population, or the sample rather, that it was designed on, but it only works with that sample. Cross-validation is essential. Likelihood ratios are helpful, but remember, cut scores always oversimplify. If you have my BMI example, someone with a BMI of 35 is obese, someone with a BMI of 55 is obese, but they are very different. Someone with a BMI of 34, someone with a BMI of 18 are treated as the same, but in reality they are very different. Remember, a cut score would treat the 19 and the 18 and the 20 as being the same, just like the 34, but would treat people who are 35, 40, 45 in BMI as being the similar. Remember, that's a little oversimplified, and you're probably better off using ratios and logistic regression. Those data aren't always available. Criteria variables in research are often artificially dichotomized. Like, is a person tall? Is a person heavy? Does the person have a cognitive deficit? In reality, those things are probably best looked at on a continuum, but remember that researchers have to dichotomize sometimes, and so that enters a little bit of error into what you're reading. And criterion variables are always measured with error. Even blood work, even height and weight, remember there's error. And questions of differential diagnosis are very important to you. Research hasn't caught up in that yet. And that would essentially include, does the person have schizophrenia or bipolar disorder? Does the person have Alzheimer's dementia or Lewy body dementia? Important considerations. It's good when you can find it, but very often the research has not caught up to that yet. So in summary, you should be able to extract a relevant classification statistics and throw it on that matrix. Use research-informed base rates. You got to go to the literature, and sometimes you got to go to your own clinic's data to find those things, but really what you're trying to find out is how often do these things occur if I knew nothing else. And now you should be able to calculate predictions by using your likelihood ratios, your odds, and the information that was included on the prior slides. And if you want some fun reading, and I think you might, The Signal in the Noise shows prediction science and a lot of examples and very little of it has to do with healthcare, but I think it's fairly good reading on some of the basic statistical principles that you can apply to prediction. Thank you very much, and I hope you've enjoyed Psychometrics 101, and I hope that this inspires you to learn more about psychometrics, as this will help you take the numbers that you gather and make it into very meaningful clinical data and something that hopefully can improve the lives of your patients.